Thank you, Mr. Chair, for this warm introduction. Good morning, everyone. Okay. Bonjour à tous, parce que les francophones, je sais que vous êtes dans la salle et il n'y a pas beaucoup de sessions où on parle français. Mais je vais demander votre excuse. Je vais faire cette présentation en anglais de la meilleure façon que je peux et je pourrais vous partager les idées que j'aurais développées après dans les différents réseaux sociaux. OK. I would like to take this opportunity to thank the International Aid Society and the South African government for inviting me to speak today and for their hard work and the opportunity they have created by bringing this conference to Durban. It is so wonderful here to be surrounded by my community and all the people dedicated to ending AIDS. Some of us were here in Durban in 2000 for this conference, and now we are back in Durban in 2016. In 2000, I would never have been invited to come and take the floor upon this stage and been able to tell you what I'm about to say. But our world has changed. At least our community of HIV and AIDS researchers, leaders, and actors has changed. From 2000 and 2016, we are making progress. I would like to acknowledge some of them here. Progress 1. Treatment has scaled in incredible ways. Progress 2. Investment in HIV have been incredible. Progress 3, efforts have been sustained the life of many, including myself. But the benefits of this intervention have not been received equally by all. And that is the next phase of this work. Achieving equity with access and scale-up of programs. I am an openly gay, which is known in public health as men who have sex with men. I am HIV positive. I am a long-term survivor of 24 years. I am an African, you can see it. I am a Francophone. And I am one of the key populations that have been neglected, ignored, stigmatized, and discriminated against since this pandemic emerged. The fact that I'm here today speaking to you means we are making some progress. I have been invited to speak to you about advancing the HIV-related needs of key population and urgency to improve our HIV services for these millions of individuals around the world. Our key population groups includes transgender persons, people who use or inject drugs, sex workers, and men who have sex with men. In every country in the world, gay and bisexual men and other men who have sex with men, sex workers, people who use and inject drugs, and transgender people shoulder disproportionate HIV incidence and prevalence, lack of access to HIV services, are criminalized and face an ending stigma. Discrimination and also violence. No country can end its epidemic unless it effectively addresses HIV in all those key populations, whether in Africa or anywhere in the world. Often, it is misinterpreted that prioritizing HIV services for key population means placing the need of some people above others. This is not my intent. Many people are at risk in every different place of the world. I'm urging us to focus on the specific vulnerabilities and clear structural barriers to HIV care for key population. In addition to this group, this poor group I just named, there is another group we should all prioritize in our HIV strategy. I want to raise to your attention those who are detainees and prisoners, many of whom are key population, and you know why, because of those criminalization of who we are, our identity, our behavior. Many of whom are key population, I said, in the special Lancet series on HIV and related infection in prisoners, there is a call to adhere to the Mandela Rule, which states detainees have a right to a minimum standard of health care, at least equivalent of that in the community. Let's go into the detail of the 4 categories of key population I cited. All of us carry this heavier burden of increased chance of infection, lower enrollment and retention in HIV treatment, care and support services, lower positive health outcomes, and greatly increased mortality. I will get into the detail of why that is in a moment and what needs to be done. Now let me show you some few slides to demonstrate what I'm saying. The first group is transgender persons, a diverse group present in every country of the world, includes female to male and male to female who may be pre-operative, in transition with hormone, or post-surgery with their gender matching their identity. And as you can see from this slide, they are not even included in national HIV strategic plans in more than 60 countries, in more than 60% of the country in the world. Another group, the next group is the people who use and inject drugs. A very special group. They may take drugs daily or just on weekends or when they are partying. This group has been highly impacted by the war on drugs. In this slide, you will see HIV prevalence is at some of the highest level in the world among injecting drug users, reaching 87% in Libya. Another group are sex workers, which include female, male, and transgender people, and others who provide sex in exchange for food, shelter, safety, and security, or out of fear of violence and harm. In this light, and in other research, we know that sex workers are disproportionately affected by HIV. In Rwanda, HIV prevalence among sex workers is at 58%. Finally, I would like to mention my group. Men who have sex with men. This includes gay men like me, and also bisexual men, men who don't identify as gay but have sex with men, and men married to women but who also have sex with men. Now, if you look at this slide, it shows that across all country income level, it is still difficult to access condom, and in addition, it is even harder to access condom with condom-compatible lubricants. This is something we have known how to do for a very long time, but we are still unable to offer these basic services or resources to our community. Men who have sex with men can be best engaged in the full continuum of HIV care when laws and norms permit us to be a formal community. But most of the country with the highest HIV burden make it illegal for us to formally organize. In Côte d'Ivoire, when at the early 2000s, we were setting the first ever organization, MSM organization. We have to go 4 times to Home Affairs, being asked to change the languages in our the proposed constitution, and also to even change our mission and go back, set us back to the closet. We have to do that in order to be registered and be able also to promote services for our community. And we have finally been registered as a HIV service organization instead of a men who have sex with men organization that we wanted. It is also important to know that each of these key population groups are not exclusive community, and that they can be overlap between each community. In fact, a person may fit into every category. What is important is to make sure we have the access to the right tool in the right place at the right time for those most vulnerable. And yet, with key population carrying the heavier burden of infection, lower access to HIV services, and greater chance of mortality, this slide shows the percentage of domestic funding does not match HIV prevention programming for us. And it is even disproportionately supported by international donors. There is a persistent resistance from many countries to acknowledge the challenge and needs of our community. We continue to face arrests, violence, and death. An example of this is the recent debacle at the UN high-level meeting for HIV, where too many countries use the power and influence to exclude key population from participating in the meeting, and language supportive of our committee was removed or watered down from the final declaration. And these are countries that otherwise say they commit to ending AIDS by 2030. We have heard a lot of talk about our goal, 90-90-90, and getting to zero new infection. We will never achieve this work without working closely with key population. In fact, success to addressing HIV among key population is the key to ending HIV in the world. Key populations have unique needs and challenges, and though we are a unique community, we are interwoven into the fabric of our country as citizens, fellow human beings, your sisters, your brothers, your parents, your children, and your neighbors, and we demand equity. We don't just demand equitable funding for HIV prevention, education, and counseling, access to condom and condom-compatible lubricant, testing, PrEP, PAP, and HIV services. We demand all of those be easy to access and delivered in a friendly environment with the highest quality of care. We demand to be free from criminalization of drug use, sex work, or HIV transmission. We demand service that meets the need of our gender non-conforming body or the type of employment we pursue. So, let me tell you a little bit about what equity means. For us, equity means universal access to all HIV testing options, and if found positive, then immediate HIV treatment for everyone. Equity also means daily oral PrEP for everyone. All of these should be easily accessible to our key population with true respect of our human rights and elimination of stigma, discrimination, and social exclusion. All these are essential to change the trajectory of the HIV pandemic among key population. We need research and data. We are missing basic epidemiological data on most key population in most communities. That means most of the time we are guessing about what we need to do. But also, we should not let lack of data stop us from starting to take action and implement programs. And we cannot allow country to continue to deny that our key population do not even exist in the country. We need to continue to develop, test, and deliver innovative solutions and great new technologies. We need to change the law that says we are criminal for loving we love, and make law that help us recover from our drug use and do not punish us for it. And also, laws that recognize that gender is not always the body we are born with, and that our body are ours to control and engage in sex, whether free or for money or to meet our needs. We need programs customized to meet the circumstance of our lives. And our community needs to be consulted and included in the development, delivery, and evaluation of this solution. One example I like to share is that I have been told every time, severally, that I'm hard to reach. Well, I have 3 cell numbers, 3. When I get here, I even took a South African number. I also have a landline, a postal address, an email, a Facebook, a messenger, Skype, even Grindr. Some may know what is that. So maybe it is partially that it is hard for you to reach us if you don't know us. So get to know us and let us help you to reach our community. Having said that, we should also acknowledge that there are still others that are truly hard to reach, such as older men who cannot be reached using those fancy new technology and instant messaging on hookup sites. So we must also consider people who cross group or don't fit neatly in the public health bosses categories and labels. There are also those such as sex workers, female or male, who work in maison close in Abidjan and elsewhere in the world. These are the ones that have been pushed from street because of abuse from police and now are harder to reach, closed off from community. We should ensure that our community group are supported to do community empowerment, since that is the basis for further meaningful engagement with programs. We welcome new ways of thinking. In this light, from paper funding linkages project developed with input from key population networks around the world, we can see how the treatment cascades have been expanded to include knowing our community, engaging us, and making sure we are tested as part of the prevention program. Then, if someone tests positive, they are immediately started on treatment and engaged in care and support by peer and outreach workers to make sure they are retained in services and achieve undetectable viral loads. All of this work is support by engaging the government and society on achieving human rights protection, supportive law and policies, and zero tolerance for violence towards key population. The key is the mobilization and continuous engagement of our community with capacity development, funding, and inclusion. So that describes the situation. As this conference gets close to the end, we have to think about what we will do as soon as when return home. We have our call to action that each of you can help us with. Firstly, we call on all public health professionals. Many of you demonstrate your commitment to us at conferences. But we really need your commitment back home. When you get there, find ways to speak out for equity and ways to engage and work with key population in your countries or region. We know this is tricky or difficult given the condition in many countries, but it is also it's always a way to work around these barriers and find a way to engage and collaborate with us. We need your courage to match ours, but be our active vocal champions, not our silent allies. Secondly, we ask that partners and funders fully and meaningfully engage with our community. This means that partners include us in strategizing, planning, implementing, and evaluating programs for our community. It means funders prioritize us and help us to ensure that our engagement is from conception to finalization, and that we are treated as experts who knows how to best address our issues. Thirdly, government. Government must fully engage and support us in all areas. Our community service organization must be able to register to do our work. They must fully fund us and include us in civil society discussion. Government must form a key population division within the health department and to focus the work. We must also address systemic barriers to equity, including government need to comply with international agreement on human rights and protect the human rights of all citizens without exception. Introduce and implement effective provision that explicitly protects all key population from stigma, discrimination, and hate crime. We are the key to end the HIV pandemic in our community. And we demand that you help us to achieve this all. Now, I need you to show your commitment to this call to action. Please stand up. If you are in the room and you are a sex worker, a transgender person, a person who use or inject drugs, and a man who have sex with men, and support this call to action, Stand up, please. Again, please keep stand. Please stand up if you know someone who is one of these key population and support this call to action. Stand up, please. Everyone else, please stand up if you agree to support this call to action moving forward. All together, let's raise our voice 4 times and demand access, equity, and right. In English, please. Access, equity, and right. In French, accès, droit. In Spanish, derechos. In Portuguese, thank you very much.